Chapter 17, Mechanics of Breathing. This chapter explores key concepts related to the respiratory system, gas laws, and ventilation. The respiratory system is responsible for delivering oxygen to the body and removing carbon dioxide. It includes structures such as the lungs, airways, and alveoli, which work together to facilitate gas exchange and maintain homeostasis. Gas laws explain the principles that govern airflow and gas exchange in the lungs. Dalton's law describes how the total pressure of a gas mixture is the sum of its individual partial pressures, while Boyle's law explains how changes in lung volume affect pressure, driving inhalation and exhalation. Ventilation refers to the movement of air in and out of the lungs. While total pulmonary ventilation measures the overall air movement, alveolar ventilation provides a more accurate representation of how much fresh air reaches the alveoli for gas exchange. Factors such as respiratory rate, tidal volume, and dead space influence ventilation efficiency. By understanding these fundamental principles, we can better appreciate how the respiratory system functions in health and disease, as well as how different conditions impact breathing and gas exchange. The respiratory system plays a crucial role in maintaining homeostasis and supporting life. First, it facilitates the exchange of gases between the atmosphere and the blood, ensuring oxygen is delivered to the body while removing carbon dioxide. Second, it helps regulate body pH, maintaining the delicate balance necessary for optimal physiological function. Third, the respiratory system serves as a protective barrier against inhaled pathogens and irritating substances, helping to keep the lungs and airways clear. Finally, it enables vocalization through structures like the vocal cords and sinus cavities, allowing us to communicate effectively. Together, these functions highlight the essential role of the respiratory system in overall health and well-being. Breathing is a dynamic process that relies on bulk flow, the movement of air driven by pressure differences. First, airflow naturally occurs from regions of higher to lower pressure, ensuring a continuous exchange of gases. Second, a muscular pump, primarily the diaphragm, creates pressure gradients that drive inhalation and exhalation. As the diaphragm contracts, it expands the thoracic cavity, lowering pressure and drawing air in. When it relaxes, the pressure increases, pushing air out. Finally, resistance to airflow is largely determined by the diameter of the airways. Narrower tubes increase resistance, making it harder to breathe, while wider airways facilitate smoother airflow. Understanding these principles is key to recognizing how respiration is regulated and how conditions like asthma or chronic obstructive pulmonary disease impact breathing. The respiratory system enables gas exchange, a vital process for sustaining life. External respiration occurs at the interface between the lungs and the blood. Oxygen from the air enters the bloodstream, while carbon dioxide, a waste product, is expelled. This exchange ensures that oxygen is available for transport to tissues while removing carbon dioxide from the body. Once in the bloodstream, oxygen and carbon dioxide are transported throughout the body, reaching the organs and tissues that rely on them for cellular processes. Internal respiration then takes place at the cellular level, where oxygen diffuses from the blood into cells, while carbon dioxide, produced as a byproduct of metabolism, moves into the bloodstream to be carried back to the lungs. Together, these processes maintain the delicate balance necessary for efficient cellular function and overall homeostasis. External respiration is a multi-step process that enables the transfer of oxygen and carbon dioxide between the atmosphere and the body's cells. First, during ventilation, oxygen from the air enters the lungs through the airways and reaches the alveoli. At the same time, carbon dioxide, a waste product, moves from the blood into the alveoli to be exhaled. Next, gas exchange occurs between the lungs and the bloodstream. Oxygen diffuses into the pulmonary capillaries, binding to hemoglobin in red blood cells. Simultaneously, carbon dioxide diffuses from the blood into the lungs. Once oxygen is in the bloodstream, it is transported through the pulmonary and systemic circulation to reach tissues throughout the body. Finally, at the cellular level, internal respiration takes place. Oxygen diffuses from the blood into the cells, where it is used for ATP production during cellular respiration. Carbon dioxide, produced as a byproduct, moves back into the blood to be carried to the lungs for exhalation. This continuous cycle ensures the body has the oxygen it needs for energy while effectively removing carbon dioxide. The lungs are enclosed by specialized membranes known as the pleura, which provide protection and support during respiration. The pleura consists of two layers: the visceral pleura, which directly covers the lungs, and the parietal pleura, which lines the thoracic cavity. Between these two layers is a thin space filled with serous fluid. This fluid serves two essential functions. First, it reduces friction between the pleural membranes, allowing the lungs to expand and contract smoothly during breathing. Second, it helps keep the lungs tightly adhered to the thoracic wall, ensuring efficient movement with each breath. This pleural structure is crucial for maintaining lung function, preventing lung collapse, and facilitating effortless respiration. The respiratory system is anatomically divided into upper and lower regions, each playing a crucial role in breathing and gas exchange. The upper respiratory system includes the nasal cavity, pharynx, larynx, and vocal cords. These structures filter, warm, and humidify the air before it reaches the lungs. The lower respiratory system consists of the trachea, bronchi, and lungs, where gas exchange occurs. The trachea divides into the right and left bronchi, leading air into the respective lungs. Structurally, the right lung is divided into three lobes: the superior, middle, and inferior lobes, while the left lung has only two lobes, the superior and inferior lobes, to accommodate the heart. Key anatomical landmarks of the lungs include the apex, which is the topmost portion, and the base, which rests on the diaphragm. The cardiac notch on the left lung allows space for the heart. Together, these structures work in harmony to facilitate efficient oxygen intake and carbon dioxide removal, ensuring proper respiratory function. The bronchi and alveoli form the intricate network that enables gas exchange in the lungs. As air travels down the respiratory tract, it passes through the trachea, which then branches into the right and left primary bronchi. These bronchi further divide into secondary and tertiary bronchi, creating a highly branched airway system. In total, this branching process produces about 80 million bronchioles, each leading to tiny air sacs called alveoli. Each alveolus is a thin-walled sac where the exchange of oxygen and carbon dioxide occurs. These sacs are surrounded by elastic fibers and an extensive network of capillaries, allowing gases to diffuse efficiently between the air and the blood. The pulmonary arteries bring deoxygenated blood from the heart to the alveoli, where carbon dioxide is released and oxygen is absorbed. The pulmonary veins then return oxygen-rich blood back to the heart, completing the respiratory cycle. Additionally, the smooth muscle in the bronchioles regulates airflow by controlling airway diameter, while the lymphatic vessels help clear excess fluid and protect against infections. Together, these structures ensure the lungs can efficiently perform gas exchange, a critical function for sustaining life. The alveoli are the tiny air sacs in the lungs where gas exchange takes place. Each alveolus is surrounded by a dense network of capillaries and elastic fibers. allowing for efficient movement of oxygen and carbon dioxide. The alveolar walls contain two types of cells. Type 1 alveolar cells are thin and specialized for gas exchange, while Type 2 alveolar cells produce surfactant, a substance that reduces surface tension and prevents the alveoli from collapsing during exhalation. Alveolar macrophages are also present and serve as part of the immune defense system by engulfing and removing dust, bacteria, and other foreign particles. The right side of the image shows the exchange surface of the alveoli, where oxygen and carbon dioxide diffuse between the air inside the alveoli and the blood in the capillaries. The respiratory membrane consists of the alveolar epithelium, the capillary endothelium, and a thin fused basement membrane. This membrane is only a fraction of a micrometer thick, allowing gases to move rapidly across it. During inhalation, oxygen moves from the alveolar air into the blood plasma and binds to red blood cells. At the same time, carbon dioxide, a waste product of cellular respiration, moves from the blood into the alveolar air to be exhaled. This continuous gas exchange keeps oxygen levels high in the bloodstream while efficiently removing carbon dioxide, ensuring proper function of cells throughout the body. The pleural sac is a double-layered membrane that surrounds each lung, providing both protection and support during breathing. This structure is often compared to a fluid-filled balloon surrounding an air-filled balloon. The outer layer of the pleural sac, known as the parietal pleura, is attached to the inner surface of the thoracic cavity. The inner layer, called the visceral pleura, directly covers the lungs. Between these two layers is a thin space filled with pleural fluid. This fluid serves two main functions. First, it reduces friction between the pleural membranes, allowing the lungs to expand and contract smoothly during respiration. Second, it helps create surface tension that holds the lungs against the chest wall, ensuring they move in coordination with the rib cage and diaphragm. Although the diagram may suggest a large volume of pleural fluid, in reality, only a very thin layer exists. This small amount of fluid is essential for maintaining lung function and preventing collapse during exhalation. The pleural sac plays a crucial role in ensuring effortless and efficient breathing with every breath taken. The alveoli are the primary structures responsible for gas exchange in the lungs. These tiny air sacs are lined with specialized cells that allow oxygen and carbon dioxide to move between the air and the bloodstream. Type 1 alveolar cells form a thin barrier that facilitates gas exchange, while Type 2 alveolar cells produce surfactant, a substance that reduces surface tension and prevents the alveoli from collapsing during exhalation. The alveoli are supported by connective tissue composed of elastin and collagen, which provide flexibility and structural integrity. Their close association with capillaries allows for efficient diffusion of gases, as oxygen moves from the alveoli into the blood, while carbon dioxide moves from the blood into the alveoli to be exhaled. Pulmonary circulation operates under low pressure, ensuring smooth blood flow through the lungs. The process begins in the right ventricle of the heart, which pumps deoxygenated blood into the pulmonary trunk. From there, blood travels through the pulmonary arteries into the lungs, where it picks up oxygen and releases carbon dioxide. Oxygenated blood then returns to the heart through the pulmonary veins, entering the left atrium, ready to be distributed to the rest of the body. This delicate balance within the alveoli and pulmonary circulation ensures that the body continuously receives the oxygen it needs while efficiently removing waste gases. The airway epithelium plays a crucial role in maintaining respiratory health by trapping and removing inhaled particles, pathogens, and debris before they reach the lungs. The epithelial cells that line the airways, along with submucosal glands, secrete a combination of saline and mucus, forming a protective layer within the respiratory tract. The mucus layer acts as a barrier, capturing dust, bacteria, and other airborne contaminants. Goblet cells within the epithelium are responsible for mucus production, ensuring that the airway remains coated and protected. Beneath this layer, a watery saline solution allows for the movement of mucus, preventing it from becoming too thick or sticky. Cilia, which are tiny hair-like structures on the surface of epithelial cells, play an essential role in clearing the airways. These cilia continuously beat in a coordinated manner, pushing the mucus layer upward toward the pharynx. As the mucus moves, it carries trapped particles and pathogens away from the lungs, where they can be swallowed and neutralized by stomach acid. This process, known as the mucociliary escalator, is a key defense mechanism of the respiratory system. The basement membrane provides structural support to the epithelium, ensuring the integrity of the airway lining. By working together, these specialized cells and structures help keep the respiratory tract clean, reduce the risk of infection, and maintain efficient airflow to the lungs. Gas laws govern the movement and behavior of gases in the respiratory system. Atmospheric pressure at sea level is measured at 760 millimeters of mercury. Gases naturally move down pressure gradients, meaning they travel from areas of higher pressure to areas of lower pressure. This principle is fundamental to breathing, as air flows into and out of the lungs based on pressure differences. Air is composed of a mixture of gases, and Dalton's law explains how these gases contribute to total atmospheric pressure. According to Dalton's law, the total pressure of a gas mixture is equal to the sum of the partial pressures of each individual gas. This means that each gas in the air, such as oxygen, carbon dioxide, and nitrogen, exerts its own pressure, which together determines overall atmospheric pressure. Boyle's law describes the relationship between pressure and volume, stating that pressure is inversely proportional to volume. As volume increases, pressure decreases, and as volume decreases, pressure increases. This principle is essential in pulmonary ventilation. During inhalation, the volume of the lungs expands, reducing pressure and allowing air to flow in. During exhalation, the lung volume decreases, increasing pressure and pushing air out. These gas laws help explain the mechanics of breathing and how air moves through the respiratory system, ensuring proper oxygen delivery and carbon dioxide removal. Boyle's law explains the inverse relationship between pressure and volume, a fundamental principle in respiratory mechanics. According to this law, when the volume of a gas decreases, its pressure increases, and when volume increases, pressure decreases. This relationship is represented by the equation P1 times V1 equals P2 times V2. In the example shown, the container on the left has a volume of 1 liter and a pressure of 100 millimeters of mercury. If the volume is reduced to half a liter, the pressure doubles to 200 millimeters of mercury. This concept is directly applied to breathing. During inhalation, the diaphragm and intercostal muscles expand the thoracic cavity, increasing lung volume and reducing pressure inside the lungs. This decrease in pressure creates a gradient, drawing air into the lungs. During exhalation, the lung volume decreases, increasing pressure and pushing air out. By following Boyle's law, the lungs efficiently regulate airflow, ensuring the body receives the oxygen it needs while expelling carbon dioxide with every breath. Dalton's law explains how the total pressure of a gas mixture is the sum of the pressures exerted by each individual gas. The pressure contributed by a single gas in the mixture is known as its partial pressure. This principle is essential for understanding how gases like oxygen and carbon dioxide behave in the atmosphere and within the lungs. At sea level, the atmospheric pressure is 760 millimeters of mercury. Oxygen makes up 21% of the atmosphere, so its partial pressure can be calculated by multiplying atmospheric pressure by the percentage of oxygen. This results in a partial pressure of 160 millimeters of mercury for oxygen in dry air at sea level. Similarly, carbon dioxide, which is present in much smaller amounts, contributes only about 0.25 millimeters of mercury to the total pressure. Water vapor also plays a role in determining gas pressures. In humid air, water molecules take up space, reducing the contribution of other gases to the total atmospheric pressure. For example, in air that is fully saturated with water vapor at 37 degrees Celsius, the water vapor pressure is 47 millimeters of mercury. To find the partial pressure of oxygen in humid air, the water vapor pressure must be subtracted from the total atmospheric pressure before multiplying by the percentage of oxygen. In this case, the oxygen partial pressure decreases to approximately 155 millimeters of mercury. Dalton's law is fundamental to respiration because it helps explain how oxygen and carbon dioxide are exchanged between the air, the blood, and the tissues. Understanding how partial pressures change in different conditions allows us to predict gas movement and diffusion within the respiratory system. The respiratory cycle consists of one inspiration followed by one expiration. As breathing occurs, lung volumes continuously change during ventilation. Pulmonary function tests, which measure these changes, often use a device called a spirometer to assess lung function. Lung volume is categorized into four main components. Tidal volume is the amount of air that moves in or out of the lungs during a single breath, whether inhalation or exhalation. Inspiratory reserve volume refers to the additional amount of air that can be inhaled beyond the normal tidal volume. Expiratory reserve volume is the extra air that can be forcefully exhaled at the end of a normal breath. Residual volume represents the air that remains in the lungs even after maximum exhalation, preventing lung collapse and maintaining gas exchange. Lung capacity is determined by combining different lung volumes. Vital capacity is the total amount of air that can be exhaled after a maximal inhalation and is calculated by adding inspiratory reserve volume, expiratory reserve volume, and tidal volume. Total lung capacity includes all four lung volumes, incorporating tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Inspiratory capacity is the sum of tidal volume and inspiratory reserve volume, representing the maximum amount of air that can be inhaled. Functional residual capacity is the combination of expiratory reserve volume and residual volume, indicating the amount of air left in the lungs after a normal breath. Understanding lung volumes and capacities is essential in diagnosing respiratory conditions, assessing lung health, and monitoring breathing efficiency. Breathing is a dynamic process that involves coordinated movements of the thoracic cage and diaphragm to facilitate airflow into and out of the lungs. At rest, the diaphragm is relaxed and maintains a dome shape. The pleural space ensures the lungs remain expanded within the thoracic cavity. During inspiration, the diaphragm contracts and flattens, increasing the volume of the thoracic cavity. This expansion reduces pressure inside the lungs, allowing air to flow in. At the same time, the ribs move upward and outward, further increasing lung capacity. Expiration occurs when the diaphragm relaxes and returns to its dome shape. This reduces thoracic volume and increases pressure inside the lungs, pushing air out. The ribs move downward and inward, assisting in this process. The images on the right illustrate how different mechanical forces contribute to thoracic movement. The side view highlights the pump handle motion, where the sternum moves upward and outward, increasing the anterior-posterior dimension of the chest. This movement is similar to lifting a water pump handle. The front view demonstrates the bucket handle motion, in which the ribs move outward and upward, expanding the lateral dimensions of the thoracic cavity. These coordinated actions ensure efficient airflow during each breath, allowing oxygen to enter the body while removing carbon dioxide. The expansion and contraction of the thoracic cage and diaphragm are essential for maintaining proper ventilation and respiratory function. Intrapleural pressure plays a critical role in lung expansion and ventilation. Under normal conditions, the pressure within the pleural cavity is subatmospheric, meaning it is slightly negative relative to atmospheric pressure. This negative pressure, typically around -3 millimeters of mercury, helps keep the lungs expanded against the thoracic wall. During the respiratory cycle, intrapleural pressure fluctuates. During inspiration, as the diaphragm contracts and the thoracic cavity expands, the pressure within the pleural space becomes even more negative. This drop in pressure allows the lungs to expand, drawing air into the alveoli. During expiration, as the diaphragm relaxes and the thoracic cavity decreases in volume, intrapleural pressure returns to its normal value, facilitating the movement of air out of the lungs. If the pleural cavity loses its negative pressure, a condition known as pneumothorax can occur. This happens when air enters the pleural space due to injury or disease, causing the lung to collapse. Without the negative pressure maintaining lung expansion, the lung recoils, making breathing difficult and requiring medical intervention to restore normal function. Maintaining the delicate balance of intrapleural pressure is essential for proper lung function and efficient gas exchange. The pleural cavity plays a crucial role in maintaining lung inflation by generating a subatmospheric pressure that holds the lungs against the chest wall. In a normal lung at rest, pleural fluid creates a bond between the visceral and parietal pleura, ensuring that the lung remains expanded within the thoracic cavity. The inward elastic recoil of the lung is counteracted by the outward pull of the chest wall, creating a negative intrapleural pressure of approximately -3 millimeters of mercury. This subatmospheric pressure prevents the lung from collapsing and allows it to expand and contract efficiently during breathing. If the pleural cavity is punctured or its seal is broken, air enters the space, equalizing the pressure between the pleural cavity and the atmosphere. When this happens, the lung loses its ability to stay adhered to the chest wall and collapses into its unstretched state, a condition known as pneumothorax. Without the negative pressure to maintain lung expansion, the affected lung is unable to inflate properly, leading to difficulty breathing. The rib cage may expand slightly due to the loss of opposing force from the lung's elastic recoil. A pneumothorax requires medical intervention to remove the air from the pleural cavity and restore the negative pressure necessary for lung inflation. This highlights the importance of pleural pressure in normal respiration and lung function. Surfactant is a critical substance that reduces surface tension within the alveoli, making breathing more efficient. This surfactant disrupts the cohesive force of water molecules lining the alveoli, preventing them from collapsing during exhalation. It is composed of a mixture of proteins and phospholipids, which help maintain alveolar stability. Surfactant is more concentrated in smaller alveoli, where surface tension is naturally higher, ensuring that these tiny air sacs remain open for gas exchange. Surfactant production is especially important in newborns. Premature babies often have inadequate surfactant concentrations, leading to difficulty in lung expansion and oxygen exchange. This condition is known as newborn respiratory distress syndrome. Without sufficient surfactant, their alveoli tend to collapse, making breathing extremely difficult. In medical settings, surfactant replacement therapy and assisted ventilation are used to help premature infants breathe until their lungs develop the ability to produce enough surfactant on their own. This highlights the essential role of surfactant in reducing the work of breathing and ensuring proper lung function. The efficiency of breathing is determined by both the rate and depth of ventilation, which influence how much oxygen reaches the alveoli for gas exchange. Total pulmonary ventilation measures the total volume of air that moves in and out of the lungs per minute. It is calculated by multiplying the ventilation rate, or the number of breaths per minute, by the tidal volume, which is the amount of air moved in a single breath. However, not all the air that enters the respiratory system reaches the alveoli for gas exchange. A portion of each breath remains in the conducting airways, such as the trachea and bronchi, where no gas exchange occurs. This is known as anatomic dead space. Because this air does not participate in oxygen and carbon dioxide exchange, total pulmonary ventilation alone does not accurately represent how much fresh air reaches the alveoli. A more precise measure of ventilation efficiency is alveolar ventilation. This is calculated by taking the ventilation rate and multiplying it by the difference between tidal volume and dead space. Alveolar ventilation provides a clearer picture of how much fresh air actually reaches the alveoli for gas exchange. By adjusting the rate and depth of breathing, the body ensures that oxygen demand is met efficiently while maintaining proper carbon dioxide levels in the blood. Ventilation plays a key role in determining how much oxygen reaches the lungs for gas exchange. While total pulmonary ventilation provides an overall measure of air movement, alveolar ventilation gives a more accurate assessment of how much fresh air reaches the alveoli. Total pulmonary ventilation is calculated by multiplying the ventilation rate, or number of breaths per minute, by the tidal volume, which is the amount of air moved in each breath. For example, if a person breathes 12 times per minute with a tidal volume of 500 milliliters per breath, total pulmonary ventilation is 6,000 milliliters per minute. However, not all inhaled air reaches the alveoli. Some remains in the conducting airways, known as dead space, where no gas exchange occurs. Because of this, alveolar ventilation is a better measure of effective ventilation. It is calculated by subtracting dead space volume from tidal volume before multiplying by the ventilation rate. If the dead space volume is 150 milliliters, then alveolar ventilation is 12 breaths per minute multiplied by 350 milliliters per breath, resulting in 4,200 milliliters per minute. Since dead space reduces the amount of air reaching the alveoli, alveolar ventilation is always lower than total pulmonary ventilation. Understanding this difference helps explain how breathing patterns influence oxygen delivery and carbon dioxide removal. During each respiratory cycle, air moves through the conducting airways before reaching the alveoli. Because the conducting airways do not participate in gas exchange, they are considered anatomic dead space. This impacts how much fresh air actually reaches the alveoli for oxygen exchange. At the end of inspiration, the lungs contain approximately 2,700 milliliters of air, including fresh air from the last breath and residual air that was already in the lungs. The first 150 milliliters of the next exhalation comes from the dead space, meaning it was never used for gas exchange. Only the remaining 350 milliliters of exhaled air comes from the alveoli. During inhalation, fresh air enters the lungs, but the first 150 milliliters fills the dead space before reaching the alveoli. As a result of the 500 milliliters of tidal volume inhaled, only 350 milliliters reaches the alveoli, while the rest remains in the conducting airways. This cycle repeats with each breath, demonstrating how dead space affects ventilation efficiency. Because some of the inhaled air never reaches the alveoli, alveolar ventilation is always lower than total pulmonary ventilation. This concept highlights the importance of breathing depth, as deeper breaths bring more fresh air into the alveoli, improving oxygen exchange. Ventilation patterns can vary based on physiological needs, metabolic demands, or underlying medical conditions. The table outlines the different types of breathing patterns, their descriptions, and examples of when they occur. Eupnea refers to normal quiet breathing, the typical pattern seen at rest. Hyperpnea is an increased respiratory rate or tidal volume in response to increased metabolism, such as during exercise. Hyperventilation, on the other hand, is an increase in respiratory rate and volume without a corresponding increase in metabolic demand. This may occur due to emotional stress or activities like blowing up a balloon. Hypoventilation is characterized by decreased alveolar ventilation, meaning less fresh air reaches the alveoli. This can result in shallow breathing and may be seen in conditions such as asthma or restrictive lung diseases. Tachypnea refers to rapid breathing, typically with a decreased depth, and is often observed in panting. Dyspnea is a subjective experience of difficulty breathing, sometimes described as air hunger. This sensation can arise from various medical conditions or intense physical exertion. Apnea is the complete cessation of breathing, which can be voluntary, such as during breath holding, or due to the suppression of central nervous system control centers. These patterns of ventilation highlight the complexity of respiratory control and the body's ability to adapt breathing based on environmental and physiological factors. Pulmonary function is assessed using tools like auscultation and spirometry, which help diagnose respiratory disorders by evaluating airflow, lung volume, and airway resistance. Obstructive lung diseases are characterized by increased airway resistance, making it difficult for air to move in and out of the lungs. Common conditions include asthma, obstructive sleep apnea, and chronic obstructive pulmonary disease, or COPD. In these disorders, narrowed airways lead to prolonged expiration and difficulty breathing. Restrictive lung diseases, on the other hand, involve reduced lung compliance, meaning the lungs are unable to expand fully. This results in decreased lung volumes and impaired gas exchange. Pulmonary fibrosis is an example of a restrictive lung disease where stiffening of lung tissue reduces the ability to inhale deeply. One of the key spirometry measurements used in pulmonary function testing is forced vital capacity. Forced expiratory volume in 1 second, or FEV1, measures how much air a person can forcefully exhale in the first second of expiration. The ratio of FEV1 to forced vital capacity helps distinguish between obstructive and restrictive lung diseases. In obstructive lung disease, this ratio is reduced due to prolonged airway resistance, while in restrictive lung disease, both values may be decreased, but the ratio remains normal or elevated. These assessments provide critical information for diagnosing and managing lung conditions, helping healthcare providers determine the most effective treatment strategies for respiratory patients. The forced vital capacity test is a pulmonary function test that evaluates lung function by measuring how much air a person can forcibly exhale after taking a deep breath. This test is particularly useful in distinguishing between obstructive and restrictive lung diseases. In this graph, the x-axis represents time in seconds, while the y-axis shows the volume of air exhaled. The forced expiratory volume in 1 second, or FEV1, is the amount of air exhaled during the first second of the test. Forced vital capacity, or FVC, is the total volume of air expelled after a full exhalation. Subject A exhibits a reduced FEV1 and takes longer to reach full exhalation, indicating obstructive lung disease. Conditions such as asthma or chronic obstructive pulmonary disease lead to narrowed airways, making it difficult to exhale quickly. In obstructive lung disease, the FEV1 to FVC ratio is decreased, reflecting prolonged airflow resistance. Subject B, in contrast, has a lower overall lung volume but a normal FEV1 to FVC ratio. This pattern is characteristic of restrictive lung disease, where lung expansion is limited due to reduced lung compliance. Pulmonary fibrosis is an example of a condition that causes restrictive lung impairment, leading to lower total lung capacity while maintaining a relatively normal exhalation pattern. By analyzing these patterns, the forced vital capacity test helps healthcare providers diagnose and differentiate between respiratory disorders, guiding appropriate treatment and management strategies for patients with lung disease. This presentation covered three key aspects of respiratory physiology: the respiratory system, gas laws, and ventilation. The respiratory system plays a crucial role in oxygen and carbon dioxide exchange, ensuring that cells receive the oxygen they need while removing metabolic waste. Structures such as the lungs, alveoli, and pleural membranes work together to maintain efficient breathing and protect against external factors. Gas laws explain how gases behave during respiration. Dalton's law describes how each gas in a mixture exerts its own partial pressure, while Boyle's law demonstrates the inverse relationship between pressure and volume, which is essential for lung function during inhalation and exhalation. Ventilation determines how much air reaches the alveoli for gas exchange. While total pulmonary ventilation represents the overall volume of air moving in and out of the lungs, alveolar ventilation provides a more accurate measure of how much fresh air reaches the alveoli after accounting for anatomic dead space. Factors such as breathing rate, depth, and airway resistance influence ventilation efficiency. Understanding these principles is essential for assessing lung function, diagnosing respiratory conditions, and ensuring optimal oxygen delivery throughout the body.